So good morning, everyone, to those that are here in the valley and those that are on screen. Well, I don't see you, but you see us on screen. Very welcome, everybody. I expect a few more people to drop in as it goes. I ran into several colleagues at the breakfast buffet, and they said, "Oh, I'll come." So there will be more people here. So very welcome. My name is Richard Bergström. I work for IQVIA. I've been a Gersteiner from the beginning, more or less. I sit on the board of Gerstein as well, and very happy to be here. We've heard over these few days a lot of talk about geopolitics, competitiveness, public health, the social contract. And I think at least I've been convinced again, not the least by the health commissioner who visited us, that actually there's no conflict between competitiveness of Europe and attaining the best public health and securing the social contract that we have between the citizens, the private sector, and governments. So there was a lot of talk these days about plans, the cardiovascular plan we heard about yesterday. A lot. People talk about the next budget cycle. For us Brussels nerds, that's the MFF cycle. But actually we have things that are already in play or coming soon. And we're going to focus on one of those today, and that's the European health data space, under this broader heading of Europe's place in the world when it comes to health. I'm joined today by two persons on the screen. We have, and I love the backdrop there, Fulvia. I always want to see the EU logo, the Berlamont logo type and blue there. Fulvia Raffaelli is head of unit at DG Santé. She's head of, I think, the digital health unit or something, very grand. So you are in charge of all this, Fulvia. I also have online here Manny, who look surprisingly fresh for being up at 3 in the morning. Manny should have been here. Manny still is with Takeda, and she's sort of a compatriot here in organizing this session. She had planned to be here. I know you were looking forward to it, Manny. But this week, if you follow the news, and for those of you that are in pharma, you know this week has been pretty rough for the industry, with everything going on between the industry and the US new administration. So all hands on deck, so Manny has to be in Boston. But we're glad to have you here, Manny. Then I have on the stage here next to me, I have Valentina Stramiello, who is acting head of the European Patient Forum, and you've seen her on several stages this week. So great to have you here. I have to her left, I have Jörgen Schøler Christensen, who has a long career in the Danish public side, university hospitals. He was chair of the Danish Medicines Council, which includes the HTA work. So now that's now part of the HTA regulation and the operations with the joint clinical assessments. Now today you'll probably hear more in the capacity as president of the newly founded organization for European observatories for health outcomes. And we'll hear more about that, both from you, Jörgen, and from Manny, who is the sort of mother of that initiative. And then finally, we have to my far left here, we have Katarina Markiewicz, who works for the new rebranded Global Health Connector, also known as the Digital Health Society. So one of the other organizers of this session, it's European Patient Forum and the Digital Health Society. And Karina, I don't think you didn't go to New York last week, did you? But there was a big launch at the UN General Assembly with lots of famous people and launching the Global Health Connector. And I'll let you talk a bit about that a bit later. I also have a side kick, can I say that? Federica here, Savataro, who's a young Steiner and who's going to help me keep an eye on, well, I said you will keep an eye on, because I don't have a computer here, what's going on online with questions from the online audience. And you just told me very suitable. She's doing a PhD in the University of Zurich on trust in sharing data. Wow, I couldn't think of anything better, you know. So I hope you also get something out of this for your thesis later, okay? So we'll have no slides today. We have a Slido though. So I urge you, once we have that barcode up and the two other screens over there, if you're sitting in the back, that you scan that. Otherwise it's Slido/health, I think. because we're going to have, I think, one word cloud, and we're going to have 2 Slidos and so on. So I expect you to be active also for people attending online. Now, as appropriate, of course, we need to start where this all started, which is at the European Commission that conceived this whole thing. And I'm expecting the founding father, I think he is André Riche, to come later. And I saw him at the breakfast, so he's going to come. So I'm going to throw out also questions to the audience here. I've prepared André to talk about this. We have Hans Palfeld here from the Dutch ZIN, Zorginstituut Nederlands, which is the entity that takes part both in the observatories that you will talk about and also in the joint clinical assessments under the new regulation. So I've prepared a few people here. Maybe I'll harass a few others too as we go on. But as appropriate, it will be to start with the Commission to talk about we heard a little bit, the Commissioner didn't give that many details, Fulvia, but clearly he made a reference in several of his interventions. He made one speech in the plenary, but then also he had several stakeholder arrangements. And every time he talked about European health data space, more in passing, but how central this was to Europe's ambition. So Fulvia, over to you to tell us about, where are we? The regulation was it was enacted in January, I think, this year. Finally printed in the official journal. So there's 2 years for that, and then 2 years for something else, and so on. So I'll let you take us through where we are, Fulvia. Over to you.
Thank you. Good morning. I hope you can hear me well.
Yes.
So it is my pleasure to be here with you, and thank you very much for the invitation. Indeed, the European health data space is a very central piece, not only of legislation, but really a platform and a project that actually projects already the future of the digital health in Europe. It is my honor and my responsibility to open this panel today, but also to be responsible for the implementation of such a big, ambitious project at the European Commission. And I'm really hoping that by the end of this panel, we will each one of us, be even more committed to make the HDS a great success. Yes, because the European health data space is a powerful European response to the current healthcare challenges, from the shortage of healthcare professionals and limited cross-border exchanges to the lagging financial sustainability and resilience in face of crisis. The HDS is pioneering project in making European health system adopt personalized approach to medicines, holding a high potential for improved diagnosis, treatment, and healthcare overall, and a great opportunity to actually improve European citizen quality of life. After 2 years of intense negotiations, the HDS is, since March, a reality. Our common lighthouse setting the direction for this joint undertaking. We're now at a turning point and at a critical time. Our challenge is to transform this incredible vision into a success that delivers tangible benefit for every European. This is a way to establish Europe's leadership in healthcare so that the European health data space becomes a living ecosystem, not just a written promise. To get there, we need the support and engagement from all different stakeholders in health ecosystem. Member states authorities, but also patients, doctor representatives, EHR system manufacturers, researchers, innovators, pharma companies, designer of new digital health services, and more. We, with the Commission, we are fully committed to this mission, and we're working around the clock to deliver a success. And to do this, we are at the moment, first of all, supporting the member states to establish by 2029 the necessary digital infrastructure enabling safe cross-border exchanging for primary and secondary use of health data. Secondly, we're working still with the member states on the design and adoption of 19 implementing acts that will define all technical specification, detailed rules and standards for the practical implementation of the HDS obligations. And we have only 2 years to do so. So everything must be done by March 2027. But we need more than that. For the success of the HDS, we need trust and transparency. Citizens trust that the HDS will guarantee the higher level protection for their personal data and transparency in who can access their data. Healthcare professional trust in a system allowing them access to full clinical history of an unknown patient. Innovative pharma and medical device companies trust that they will have access to multi-country and population health data to develop new drugs and therapies and to train their AI-based solution algorithms for precision and personalized medicines. This is why the trust element is built into the requirement of the HDS, which includes cybersecurity, data protection standards, ensuring that we don't put the patient health at risk and that patient re-identification is prohibited and avoided. Of course, we are part of a holistic approach that involves the careful implementation of other regulations, such as the GDPR, the AI Act, the medical device, the NIS2 directive. So we are working very closely with the colleagues in the different departments to ensure a smooth implementation of all these regulations together. Our commitment is backed by sound financial support through different EU programs, EU for Health, Digital Europe, Horizon Europe, and we're starting already to think about what next into the next cycle, financial cycle. The HDS is a joint European effort, and the NICE objective would not materialize without a close EU cross-border cooperation for capacity building and deployment. And here, interoperability is the key factor that will determine the success of the HDS, allowing European individuals to access their personal data and enable the share of those data freely and safely across border. It is, of course, the HDS, and this has been said many times in the different settings, a key element for competitiveness, because the main objective is to made available many types of data sets for scientific research and analysis, supporting policymaking of European researchers, and enabling faster collaboration on critical areas such as cancer, rare disease, cardiovascular, while of course encouraging European industry to build an integrated single market for digital health services and products. We're working on the present of the HDS, but already have in mind the future. And we see the HDS as an enabler for innovation and competitiveness, especially through the transformative potential of artificial intelligence. By enabling the secondary use of health data to train AI system will allow the refinement of algorithms, promote the integration of these tools in healthcare systems, and demystify their use for health professional and patient. The digitalization of our healthcare systems paves the way for new sectorial data spaces, which trickle-down benefit for the rest of the European economy. This has been reported, and we are very happy to build upon the latter reports that we aim to create this fifth freedom, meaning the free circulation of researchers, scientific knowledge, and technology in the EU single market. To conclude, let's think for a minute how much digital health has advanced since the COVID-19 pandemic. Europe, at that time, braced itself against this challenge and promptly responded through the creation of the EU Digital COVID Certificate, a revolutionary tool that established the EU as a standard setter in the matter of pandemic response. The certificate are now transitioned to the WHO, Global Digital Health Certification Network, for the continued global issuance and verification of digital COVID of other certificates, with around 80 countries now connected. This is a big recognition of the EU developed solutions and a demonstration of the success of this invasion. Well, we have the same vision and ambition for the EHDS. The European health data space has the potential to inspire, teach, and lead the way in strengthening health systems worldwide by making them more adaptable to modern needs and by unlocking the potential of data with always the patient at the center and the protection of privacy as a key principle. So the direction we're taking is one towards a data-driven European society with the cross-border collaboration standing at its heart. So are we all motivated to make of the HDS a success? Thank you for your attention and looking forward to the panel discussion.
Thank you so much, Fulvia. Thank you. And I'm very happy you ended on that note, because this is really what I hope will be the sort of red line through this session and with the questions that we prepared, is actually to talk about that motivation, not simply complying with the new regulation, but actually people should be motivated. I don't know how many of you have read this piece. I've read it probably 10 times, and my wife was peeking over my shoulder and saying, "What are you reading, Richard?" European Health Data Strategy. But you read that last week. Yes, but I have to read it every week, over and over, to understand it. So there's a challenge in, and I keep saying this to people, that you have to somehow first disaggregate EHDS into its components. And you mentioned, Fulvia, it's what I call EHDS 1 for primary use and EHDS 2 for secondary use. I think the focus here will be mostly on secondary use. But you have to disintegrate it and then aggregate it up again. So then when we look back, you will see the totality of it. It reminds me also of the journey. I'm old enough, you see my gray hair. I was around in the industry when the EMEA was set up in London back in the days. That was a huge project. And look now, it's beautiful, you know. And in the beginning, there were some people saying this will never work and so on. Look, this is similar. This is as big. This is going to be a 10-year journey, Fulvia, right? This is going to be, we have to have patience, and we have to take it one little step by step, and then it'll look as a totality towards the end. I want to turn to you, Valentina, because, I mean, you represent, you're the authoritative voice, if I'm allowed to say that, for patient representatives on the Brussels scene, you know. So for this to work, we all believe, I think, that patients need to see a value. I mean, one thing is that you will allow the data to be used, and we're going to come back to this, as you have the chance to opt out. That's in the legislation. But beyond that, and I know that many will want to talk about this later, and also you, Jörgen, it goes beyond that. It's not just that data that is there today that people can see it, but it's also engaging patients and actually sharing their experience. It's an interesting consultation, by the way, for the nerds in the room by the European Medicines Agency that was launched this week on patient experience. I think that's the term we should use, because it goes beyond outcomes. It's much more than those metrics. It's much more. Valentina, what do you think can be the value for patients to actually participate actively in this as well?
Thank you for the question, Richard. As a patient community, we see value on multiple levels. On the individual micro level, we see a value for patients because the capturing their outcome may support their relationship with healthcare professionals. As far as this data is returned to the patients, they are able to see directly how their outcomes compare to other patients, and they can also better communicate to healthcare professionals about any potential side effects or how they cope with their condition. But there is a value also on the systemic level, which is more interesting for me personally, because I have realized soon how these aggregated data can support evidence-based advocacy for patient organizations. We often are asked to support our communities to have access to better treatments. But how can we do that if we don't see the data and compare how a treatment performs compared to others? So through this approach, I think there is an opportunity for patients to have access to high-quality healthcare across Europe. And of course, it can be also perceived as a way to raise the competition when it comes to the technology developers. But I see also as putting the bar higher on the quality of care, because at that point, patients will be able to see what is accessible, what is affordable, and what is achievable. And so they won't be bound anymore to the care they were prescribed. but they will see that there are more chances and maybe better chances.
Yeah. No, it's interesting. In many parts of society, we have much more of comparisons, and we as citizens can compare whatever it is, restaurants or airlines or whatever. Healthcare is still a bit not that well sort of understood by citizens. I'm going to come back to you in a second. We have launched a Slido here in the background for those that are in the room and those online. I think you should see that. How confident are you that Europe will become a global leader in using patient outcomes and real-world evidence for decision-making? And decision-making being everything, that's important for this conversation. Decision-making is the physicians, hospital managers deciding on protocols or treatment pathways. It's the regulators, of course. It's the HTA bodies. It's pricing, reimbursement. So how confident are you that we will become a global leader? Look at this. That's not bad. Okay, it's 3.5 average. Okay. Yeah, I guess there's some doubts about the realism maybe in some of the aspirations, I suppose. But now, Valentina, the other thing which you've been confronted with, I know before, because when policymakers and stakeholders on the Brussels scene, they want someone to talk to and consult, they tend to come to you, and then you have many colleagues in more specific patient organizations. But when it comes to citizens at large, because here we're talking about people that don't think there are patients yet, sharing their data as well. So how do you see your role and the EPF's role? Will you be representing citizens at large? Or maybe, if not entirely, what are we going to do about that? How do we make sure that we have the NGO, civil society in general, participate in this? Because I think your members are very motivated, aren't they?
Our members and the patient community at large is usually motivated, and they see the opportunity of data sharing because they are very much aware of the need of data to support research. Of course, when it comes to citizens, I can't say we do represent citizens at large, because this is what makes the big difference between patients they are experts by experience. That now this is a new terminology. That's because they live with conditions for the whole life. And so this enables them to better understand the implications, that they become familiar with healthcare systems. And so we can't say we do represent citizens, but we may be ambassadors and promote data sharing. As EPF, we have initiated in 2019 a collaborative effort called Data Saves Lives, which is meant to target patients, but it can easily target the whole European population, actually. And the primary purpose of this initiative is to raise awareness about the value of data sharing. And I think we are now at a point where we need to reinforce and repurpose also these efforts towards a larger population. It implies that probably we need to collaborate more closely with consumer organizations, citizenship organizations across Europe. And of course, whether it's doable, I'm not sure. It requires a lot of resources, probably. We need to make sure that all these concepts are understandable, accessible to the wider population. We need to make sure that the implications are well understood. So we need to really bring all the key topics. You said you read on a weekly basis the European Health Data Space. Imagine what it means for a patient or a citizen who's not aware of the terminology, the jargons, and the technicalities. So it means that we need to translate all these key concepts in something accessible for the layperson.
Yeah.
And but I think it is doable. And listening to Fulvia earlier, I found it so exciting. I mean, I think we can do that. I hope we can achieve a better result at the end of the session.
Yeah, maybe have a rerun at the end and see, or maybe not. Now, so about sticking to this or talking a bit more about this sort of awareness, because I mean, motivation comes from that. You need to be aware and excited and motivated. So I want to go around a little bit here in the different domains and explore awareness. So to you, Jürgen, having been both a hospital director and then very active on HTA. So we know for sure that the regulators of the European Medicines Agency, they've been onto this with real-world data for quite some time. We have a project called Darwin that also my company is involved in, which is sort of a front runner for EHDS, which is about harvesting real-world data for their decision-making, both on effectiveness and safety. But how is it in the HTA world, which has come a long way from when this all started with NICE in the UK, and then we had the TLV in Sweden, or LFN in Sweden. It's come a long way. So what's the interest from the HTA side? I mean, do HTA assessors care also about real-world evidence and looking at this in an iterative manner over time? You want to comment on that? And then I'm going to throw that question to Hans here from the Dutch agency as well.
Let's begin with, we actually like the EHDS as a possible ground to create more real-world evidence, which we need. And as an HTA body, we certainly need more patient outcome data from the patients. Because sometimes what the healthcare professionals actually acquire of data is not precisely what the patients experience, sad to say. Sometimes there's even a huge difference between a success on the results on the PFS, OS, but the patient's quality of life has been ruined. And we need to acquire that knowledge so we can take it into consideration when we do the decisions. And I had an example last week where clinicians told that they'd done a beautiful scientific research job comparing two drugs. And the clinician says, these drugs are comparable, they're okay, and we talked with a lot of patients and they're okay. Then they interviewed the patients, and it turned out that one of the drugs had nasty side effects, not huge side effects, but nasty. They couldn't sleep, they had skin problems. So actually one of the drugs was clearly superior to the other. And the science behind it didn't show it. So kind of sharing the Danish system, I've decided years back, we need more patient voice into evaluation of new drugs and others.
So HTA is not a one-off thing and then you forget about it. It's iterative. Actually, it's where HTA started. At that time, we didn't do HTA at the time of launching a medicine. We did HTA years into the market with Cochrane analysis and everything, you remember?
No, you need to carry on. And you need to be precise on it.
Yeah.
Meaning a lot of us is actually in the HTA bodies making follow-up systems so that we introduce the treatment and then we continue to learn from what we are doing, real-world evidence. Yeah. And we learn from the patients as well. And when you compare it, and I've been into it with the Danish Medicine Council, it's amazing what we see, because drugs are not only given to the ones who were in the study population, they're given to fragile over patients and to younger patients and whatever. So you need to collect the real world data to evaluate on a long time scale.
Yeah. More and more clinical trials are perfect for the selected population. True. Now, can we get a microphone here to Hans? But first, I want to ask you again, Jörgen, just to expand a little bit. I know you can probably speak the whole morning on this, so if you're brief, please. But what I found so fascinating with the observatories that you're setting up or have set up is that you do this by therapeutic area, and you really aspire to have patients participate in addition to health records and everything. So which areas have you set up, and what's your ambition to expand this to other areas going forward?
It's just now like 5 years since the H2O Health Outcome Observatory.
So Google this, H2O Observatories.
Yes, Health Outcome Observatories. And it began creating in different disease areas like IBD and so on to collect data directly from patients who wanted to provide patient-reported outcome. And it was rather difficult. It was before EHDS, and you had to do all the legal work. But the patients and your organizations were positive, the hospitals were positive, and this project succeeded in collecting a rather huge amount, more than 4,000 patients, data concerning what patients experience during treatment. And it turned out this is really important to know what they experience. Yeah. So we created the follow-up, which is an organization called Pan-European Observatory, which is an organization, non-profit, thought to cover the same task, like trying to expand the number of countries that we are working in from 4 to more, expanding the disease areas, but focusing on patient-reported outcomes.
Yeah. And I'm sure many will like to come to you in a few minutes, Manny. I'm sure you want to comment on this. This is also a front runner, you know, sort of even before EHDS is fully implemented, you're already running with it, like Darwin that I mentioned. Now, Hans, in your organization, you're at the Zorg Institute Nederland, so this is the HTA agency in the Netherlands, part of the new process under the HTA regulation. We're still in the early days. I think how many reviews are ongoing? 20 maybe? Nothing's come out yet, but this is in parallel with the EMA that the HTA agencies do a joint clinical assessment. Hans, how is it with your staff, your colleagues that are engaged? How much are they already realizing that you may have to not delay the decision, I hope, but the fact that you will need more real-world evidence over time? How much has that come up now in the early days of this new process?
Well, can you hear me?
Yes. Yeah, they will put it in. It's on. Starts with.
Well, whatever. Me being here indicates that we understand the importance. Me being here by myself also indicates that we don't really prioritize it. So I fully agree with Jürgen that elements like quality of life should be part of the normal measurements. It's a quality of life however you measure it. We still need to define what outcomes we think are important, because I don't hear that here at all. But both clinical outcomes as patient outcomes are not yet defined. We need to define them more thoroughly, and I know from the Netherlands that's a big struggle, and pan-European that might be even bigger struggle, because we don't even define the outcomes. We talk about outcomes, but we have no definition of the outcomes in most cases. About using real-world data, it's been an ongoing struggle. There are people in my organization that are aware of this for 15 years. And I would say the majority of people still do not think at the current level we can use much of it, because we do not always have the right data. So we didn't define the data that we need for our assessments. And there's always the lack of quality of data. So we are kind of hindered by that. I myself think we can already use a lot of data. I even think we can use, and that's a very, it's not a very high quality data, it's a proxy, but declaration data has been used by us by a large amount. I even set that up in my organization 10 years ago, and we're using that to our great advantage. So there are proxies where we can define what's the outcomes and what's the results of clinical treatments and diagnostics. But I wouldn't say it's mature yet.
Oh. Okay, thank you, Hans. You're welcome to come back later in the discussion as well. I want to turn now to Manny over in Boston. So, you know, how is the industry, now you're representing the whole industry here, Manny, feel the pressure. How is the industry engaged in making EHDS come into play and be a success?
So first of all, I would say that from an industry perspective, we do see the EHDS as a turning point for Europe, or potentially as a turning point for Europe. The biggest cost for industry is our clinical development. And if there was a way to capture real-world evidence digitally, but in a standardized way, as Hans just said, then this would mean that we will have much better evidence to go through the joint clinical assessment and be able to discuss with HTA agencies about the effectiveness of the drugs both at the launch as well as during the life cycle of the drugs. Because from an industry perspective, we do understand the importance in Europe as well as elsewhere to proceed to an outcomes-based reimbursement. But an outcomes-based reimbursement means that you need to be able to monitor the outcomes of the patients on a population basis in routine care. Now, one of the things we have discovered with the H2O project is that patients are willing to participate in this endeavor, not to collect data, but in order to have a better communication with their physicians. And that is critical. If we give patients and physicians the possibility to communicate digitally, but in a standardized way, and I really appreciate, or I'm very happy that Hans already mentioned that the importance of the standardization, then we create a common language. And this common language starts generating data which can be of a much better quality to what we currently capture. Because again, to go back also to what both Jürgen and Hans mentioned, for an HTA to be able to make use of the data, they need to be of an appropriate quality. So creating a process where to give a vision already at phase 2 or prior to phase 2, there is a forum where there is an agreement among the HTA agencies, the regulators, the patients, and the clinicians on what can be measured routinely in the real world, which cannot be the same to what one measures in the clinical trials. There's no way we can measure the same things in routine care because it would be too intensive, too intrusive, too difficult. But there is a way to agree among all the stakeholders on what can pragmatically be measured in the real world. So if there was a way to have this type of standardization or agreement, consensus, at the beginning of phase 2, then industry could engage with projects or initiatives such as the observatories to start collecting this data in the real world and creating these fantastic real-world libraries, which could make Europe the new laboratory, or make Europe again the laboratory for life science across the globe. It would become a fantastic way to also support the optimization of clinical trials and the clinical development in the European globe. So this is why, from an industry perspective, this can be so exciting.
Indeed, and that is why this will contribute to competitiveness.
Exactly.
These days it's all about the data.
And
data is the new oil and all that. And as you say, if regulators and payers and HTA assessors know that these things are now doable in the future, this will change the conversation when you go there for early dialogue, for scientific advice, where you have all the parties in the room and you can design whole new approaches. Yes, Annie?
And what I would really like to stress is what I think is the most magic here is that the secret for that is to achieve a good communication between the healthcare professional and the patient. Yeah. And that is why I think that what's so important in the discussion we are having is that the catalyst for this transformation is really patient empowerment. Yeah. But patient empowerment in a way by giving them this standardized language to make this happen.
So thank you, Manny. We are going to come back to this towards the second half of this panel about motivating and engaging patients. We'll have a Slido poll in a few minutes. But before that, I want to turn to you, Carolina. So your organization, you've been under different names you've been very active for many years, and there's a whole community that work with ontology, semantics, interoperability, standards, everything, right? And it's been maybe mostly for primary use, for making healthcare operate, but also on secondary use. So that community that have worked along with various initiatives, we have many IMI initiatives, Eden and many of them, Elixir, all sorts of data initiatives. That community, Carolina, your community, if I say that, you know, how engaged are they in this? And how much are they willing to work with the Commission and others and member states to make sure that we don't reinvent the wheel, because there's a lot of work that has already been done.
Right. Thank you, Richard. This is actually a very packed question. And also the community that I represent is very diverse. So we are a global health connector, and we are a non-for-profit organization that brings together all stakeholders engaged in digital transformation of healthcare. And I will maybe start by referring to the question of awareness, like how aware the community is. And of course, when we work with the EU-funded projects, with IHI's project, with Horizon Europe, there is a lot of people from the academia, from the industry that know EHDS very well, and they know about health data interoperability. There are people who work 2-3 decades on this issue, and this is their daily bread. Then there are, of course, the startups and the healthcare smaller companies. We know that, of course, the big companies, the industry, they know and manage to unpack EHDS over the years pretty well. But I ran a session during the event called Health Europe in June in Amsterdam. Packed audience, more than 100 people representing smaller, bigger companies. And we ran the session on EHDS, and I asked, how many of you know what EHDS is? So, you know, there were some hands here. I assume you all are aware about EHDS. You came to this session. Then I was like, how many of you know what EHDS is about? So there was like maybe 10 hands. And then I asked how many of you read the regulation. So of course, people like you, Richard, that read it weekly, 3-4 people. And of course, my panel that work on this. So that shows that there is still lack of knowledge and awareness what really EHDS can bring. There are some, of course, news posts, blog posts, podcasts organized, published on this issue, but there is no like deep knowledge that actually what EHDS brings, what kind of responsibilities, but also what kind of benefits. And I think that this is something that we should be aware of, we should recognize, we should acknowledge, because if we want to become the leader in health data sharing, we need to mobilize this community and mobilize it beyond events, conferences, and so on. I think we have very good mobilization during the events. Everyone wants to know a little bit and is excited and wants to discuss the risks and barriers, but also the benefits. But we need to go further, and there is lots of work to be done. So coming back to the leadership, we definitely, I think this is not a choice. This is something we must do. We must become leader. Otherwise, what else is there for us here in Europe? And coming back also to the title of the conference about the solidarity, this is also thinking about the state of our healthcare systems. This is also something we should do to improve the healthcare systems and the patient's position in the healthcare system. So, responding to your question, the community is so diverse that you cannot really say one thing. Like there are people who are deeply involved and are looking forward to HDS, and those who should still be, I don't know, educated, engaged. I think engagement is a very good word here. Right?
Absolutely. And being aware that all the details have to be worked out. I mean, I run into people that have tried to read this, and they say, well, what about this and this and this and this and this? Well, guess what? People are working on that. You know, Commission, you said that, Fulvia, you know, you have a long series of implementing acts. You have some delegated acts, if you care about the difference. You have guidelines, you have templates. There's going to be a logo type for this even. You know, there's all sorts of things that you're doing. You're supported by a joint action called TEDAS 2. There are a number of other EU-funded initiatives. You're giving grants to the member states now to set up the health data access bodies. You know, so there's a lot going on. And I guess part of this, Carolina, is that your community gets involved in that. And I know they show up when TEDAS has stakeholder consultation. There are always people coming. Now, we need to really keep an eye on the patients here and citizens at large. You know, so we're in a word cloud now, I think we said, right? If patients are to share their health outcomes, what do they need most from the system? So fire away. What do they need the most from the system? Solidarity. Reaction. Okay, so it's not a one-way street. Okay. Accountability. So security, would that be sort of cyber security, privacy protection? What do you think? How to interpret that word? Transparency, we have two spellings there, so we add them together and then it's a bit bigger. Trust, yes. Yeah, those are all related, aren't they? Accountability, security, you can call that also privacy, I suppose. But trust and transparency, who's seeing my data? And that's actually a feature, particularly under EHDS 1, looking at you, Fulvia, is the fact that you have this logging. There will be logins also, but there will be logging. You should be able, like you have in Estonia, you know, you can see whoever sees my data, whatever it is, you know. In healthcare or in society at large, I can see who looks at my information, which is the intention, I think, of the EHDS to have that for health. Okay, but yeah, to be really heard, we have feedback. Yeah, so there's not a one-way thing, one-way street. There has to be some value back to the individuals. And you made the point. Was it you, Jürgen, that made that point, or many, about improving also the conversation between physicians and patients. So it becomes sort of something active. It's not a one-off question. Do you want to share your data? Okay, fine, then we will use your data, right and left. It has to be something more. You're shaking your head that many. You agree with me on that. So it has to be very active, very live for the citizens. Now the legislation allows people to opt out. Okay. Now, sorry if I sounded a bit scathing there, but you know, this is the reality. This is what's needed politically and everything. You know, you need to have that possibility, and not all member states had that to have that today for secondary use of data. The country that I know best, Sweden, if you're in the healthcare system, your data will be used. GDPR applies, of course, and some when ethics committee approvals to some studies, but otherwise my data is there to be used. Now, everybody has to introduce these opt-out mechanisms, and even there's a possibility for member states, they don't have to, but there's a possibility to even have an active consent, active opt-in for certain types of data, sensitive data, genetic information. It remains to be seen what member states, if any, will introduce that, but we'd have to deal with this fact. So we're not going to do a slide on this. I just want to have people raise their hands. Is this going to be a problem? Do you think that many people will opt out from having their data being accessed for secondary use, for research and so on? Do you think this is going to be a big problem? Will many people opt out? What do you think? I'm not asking about you, because you will all opt in. I know that. But will many people opt out? Hands up, just. And how many think that this can be managed? We're not going to have lots of opt-outs. Okay. Yeah, almost equal number of hands up. So, okay, so we still have faith in that working. You hear from what I say, I have a slight bias here. I want people to be in, okay? But we have to be cognizant of the fact that this has to be allowed, okay? Now, I want to see if we have any questions in the audience. We have one there. That's Magda, isn't it? I see you, Rosenmüller, from the business school, Spanish business school in Barcelona. And then I'm going to turn to the online audience after Magda. Yes.
No, just very briefly, I think the only way to work with this, and that's in the patient sense, is to make it useful for patients, that they can monitor themselves, that they have actions they can do upon the data, because then they will continue to collect those data. So that's not only useful for us or for whatever we would look into it. And then it hasn't been touched upon is that when we have a lot of reliable data, even if it comes from the wellness, not necessarily, won't go into medical device problems around all this. Even if you only have wellness data, there's this richness that with the use of AI, we can make knowledge and information out of that we won't expect. So I think make it useful for patients, I think, is the most important, and have them self-monitor, give them work to do, give them like, go and pace yourself in the park, and let's see that there's a richness there that we haven't really tapped into. Thanks.
So that feedback loop is important to make this live and active. And what's in it for me? I mean, there's a whole conversation starting or ongoing about benefit sharing and, you know, what do I get out of this? You know, and also from a hospital perspective. I mean, you've been running a big university hospital. You know, what's the value for the hospitals in curating? Because I mean, we know that those of you involved in clinical trials, in my company we do a lot of clinical trials, there's a lot of curating. You have to chase data and clean data and so on. So what's the motivation for the hospitals, particularly university hospitals, to be investing in this? And what's the value? Is there money involved in this?
No, but somehow money is involved, as always. I think you have to divide the answer in two: hospital management and staff, because there might be differences. I've seen management being really engaged in using patients' voices, in trying to shape what we do at the hospital, trying to reduce the length of stay, because patients actually do like to be at home, and reduce the number of outpatients physically visiting the hospital. Still, patients normally like to stay at home. They don't like to go quite so often to the hospital. So that's management, and we can see a huge opportunity in reducing cost and taking care of more patients and doing more for them. Physicians, like nurses and so on, they might think, okay, we will do it if we can have some, and the patients, of course, have some benefit from it. And the benefit for the hospital staff will be, they like to feel proud and to feel excellent. So if we inspire them by giving them access to data, so they feel excellent, doing a nice job, and perhaps a little bit efficient as well. They like that. But otherwise, if we just put it there and say, you need to do this and that, it won't work. We need to give value to them, and they need to experience that the patient have value as well.
Yeah, so that is really a red line here as well, or the red thread through this is motivation. Everybody, from healthcare professionals to patients, citizens. Now, Federica, how does it look online with questions?
Hello, yeah. Got some very interesting questions from the online audience, I'd say. So a few questions are actually linking back to the engagement and awareness of patients and citizens. So they're asking whether there are any structured awareness communication programs. And there is also another question that links back to the awareness aspects, as they're asking, can the EHDS be implemented faster? There's a long timeline, which means perhaps also the complexity of the program itself is not super clear. Another interesting question is about how to avoid that the HTS will use the data in order to discipline citizens and patients, meaning leading to division between who deserves treatments and care and who doesn't deserve it. So those were two, among others, questions that were posed.
Yeah, so I'll also ask Fulvia to comment on this in a minute, but that last point is very important. If you follow what discussions, particularly in the United States, where you have the insurance system, you know, where you have this revelation that AI algorithms are deciding whether you get the treatment or not. No person involved at all, even though that's what the insurance company said, that there will always be a human being involved, but it turned out not to be the case. So that comes with a lot of responsibility. We haven't spoken much about AI here, actually. Did anybody say the AI word before I did now? No. And we'll get back to that maybe in our slide of poll, you know, because who will benefit from this? I mean, all the AI developers, we don't see that many people coming to the Valley, to Gastein, but they certainly were at that meeting that you attended, the health conference in Amsterdam. But this question about the structure, you know, structure approach to create awareness and in the population, Fulvia, that's part of the, it's in the regulation, tasks for you and the member states, right, to do that. But when will that come? Is that going to come towards the end of all these years, or is it something that you think will come earlier?
Well, I see you read it very carefully. Indeed, there's the regulation. Yes, indeed, there is an obligation for to support and work with the member states about raising awareness and training and educations of the different actors. But what I would say is that, of course, this point of communication is very, very important to build the trust into the system. And we need to organize that communication, I think, in my view, in waves, because indeed there is still quite a long time before the patient is, or the citizens that we are, will be impacted by the HDS as such. So we need to take time to build that trust and to inform the different actors. So in first place, we are at the moment aiming and working already with the member states and with the healthcare professionals. We have a capacity building exercise project, and we do also have a communication ongoing so that we prepare toolkits for the member states to actually really inform them. And then the professional can multiply, because of course the doctors is the interface with the citizens or with the patient, and if they do trust the system, they can also transfer and share this trust into the future HDS. So yes, communication is very crucial, and I think that the whole HDS is designed to really provide that trust. A lot of safeguards are in the system, and not only from a procedural perspective, but also from a digital infrastructure perspective. So with many safeguards to keep secure the data that are made accessible by the system. Because in many cases we say we share the data, but share, it looks like we're putting the data there and everybody can go and look. But in fact, this is not exactly what is happening with HDS. The HDS is the system that gives access to data, both in primary and secondary, after, let's say, according to several conditions. So it is not about sharing an information that everybody can pick up, but it is about really creating the governance and the conditions to access data. And this is, it is important because both in primary and in secondary, there is a whole set of safeguards and governance that regulate this access to make it transparent, traceable, and indeed to allow two-way communication, so also getting feedback from the system. I would just want to take the opportunity to react on something that Valentina said before about the role that patients can play in being the ambassadors, because indeed one of the bigger revolution of the HDS, if compared with the current situation, is that we go population-wide. So the ambition of the HDS is really to involve into the system all the citizens. And sometimes there is this, the one where the opt-out is more, let's say, common, or the ones that are more, let's say, suspect of the system are often not the patient, but the ones that are not in very health situation. And this is what I call in many cases mutatis mutandis a NIMBY, not in my backyard. So today I'm healthy and I keep my data for me. Tomorrow, by the way, when I'm gonna be sick or having a chronic disease, then I would be very happy to actually profit of the drugs which are being tested on the data of the others. So I think there is a very strong notion of solidarity here that we need to communicate to the audience, and to really ensure that the population-wise ambition of the HTS does profit to the entire population, and this must be understood, that the patients, of course, are critical ambassadors for us to actually pass this message of solidarity and fairness across the entire population. If you want to go faster, we're ready to go, but of course, this is something we need to look also with the member states, and I must say that it's from a technical perspective, it is a very complicated project, so we need to get it right also as well.
Yeah. And on the speed thing, I'm not going to press you on shortening things, but keep in mind that the secondary use actually kicks in slightly earlier than all the rest, right? Because the health record companies have 6 years to implement all that from starting earlier this year. Whereas I see already that many member states are really ahead now, or working on health data access bodies and getting going. With the Finns already have system in place, the French have it, and others aspire. And I think it will be a bit of a healthy competition maybe to get going on those access methods. It's not going to take all those years. I think we will see this start as soon as all the details are ironed out from the Commission, which is not that far away now. You feel the pressure, Fulvia, anyhow. We don't have to talk more about timing. Karina, you wanted to come in on this one, and then we're going to do another slide.
Yes, I wanted to comment on the communication campaigns and also circle back to opt-out. As the Global Health Connector, we ran 3 weeks ago, the roundtable, multi-stakeholder roundtable on the risk of bias in data for AI, but I know that AI is not the scope of the session. I will take what's relevant for this discussion. And of course, with the experts from many fields, we discussed what are those risks of opt-out and why this opt-out, why people might want to opt out. And I think that we are here in this discussion. We have EHDS, we will run the campaigns. We are in this positive scenario. We are here, in 10 years we will be there. Everything will go according to the plan. But maybe we can do this post-mortem exercise. We are in 2035 and things go terribly wrong, and think why they went terribly wrong. What might be those things that affect us, and how to prevent them. And I think that one thing that we didn't touch yet are also that there might be misinformation campaigns. So there might be different, and we've heard yesterday, I was at the session about the resilience of Europe healthcare systems. Of course, we talked a lot about the public health being very much politicized. But already from the discussion preparing for EHDS, we heard how opt-in and opt-out can be politicized. So I think that it would be great, and I would advocate for that. I think that this would be also one of the calls to action, to be prepared and not to be reactive to those potential misinformation campaigns, but be prepared for them, because we know that they will happen. This is something that if we want to learn from COVID, we know that this happened. If we want to learn from other sectors, we know that this will happen. This happens with the Green Deal. The Green Deal was so attacked that it almost collapsed. So I would advocate, and also this is not only to Fulvia, this is of course not to the European Commission, this is to all of us as the community, not only to have those pink glasses and think that everything will be beautiful, and if people don't understand benefits, we just need to educate them more, but be prepared that there are also other forces that maybe don't want us to lead on this matter globally, right?
No, let's not be naive. We need to have our eyes wide open on this one. And it goes back to points that both Manny and Jürgen and everyone's making here, is that the closer you bring this conversation to something between your healthcare professional, your doctor, and the citizen, a patient. You know, if that conversation there, that's where the conversation is. It's not going to be mass emails to the population. Do you want to share your data? Yes or no? You know, and without any details on for what, right? That's going to be dangerous. So I think now, in the interest of time, also we're going to do one final Slido, and then some maybe quick comments to that. It's going to be very interesting to see. So this is a multiple choice, so you can actually click many, which is important here. Who would benefit, or what sectors, what people will benefit from the secondary use of data under EHDS? So which of these above? And you, as I said, you can click all of them if you want. Oh, many, you're up there at the top. Pharma, medtech industry. Tech industry, including AI. Yes, I listen to you, Carolina.
Academic research.
Less on regulators and payers.
Okay.
Okay, so we friends, we have some work to do here, because if we at the outset of this session and when we designed this and the questions, you know, we wanted to really put the patients here at the center, citizens and patients, to have them motivated and engaging. And if this well-educated audience here is not convinced that the case is there, you know, we got some work to do.
But maybe we can also think that, of course, if the medtech industry or pharma benefits, then those benefits also go to the healthcare system, right? Of course, this is also the matter of trust,
you get new medicines and devices.
This is the matter of trust and solidarity.
Yes. No, it's not negative, but I think that for the comment you made earlier, if this is the general perception that the main beneficiaries of this is going to be industry and you know, tech as well, not this pharma and tech, you know, who's the most trusted or not is another conversation these days. Any other comments from you here when you see this?
Yeah, I think it's the system that benefits to me. It's not just one stakeholder group, but the whole system. And if we link this to the discussion around Europe being more competitive, and it's also a matter of supporting and defending European healthcare systems, which are now a bit under attack. And so the way to promote our way of delivering care to patients in Europe, we need to also innovate the way we deliver it. Yeah. And I think for patients and citizens, it may not be immediate because they are maybe the biggest contributors, and the result for them is not immediate, probably. But that's where we need to build resilience. And indeed, as Fulvia was saying, maybe I'm a citizen today, who knows whether I will ever be a patient. And so the outcome for them may not be visible in the short term. But again, that's where solidarity comes. This data is going to benefit the whole system. It's going to benefit research and access to potential new treatments that can be more beneficial to other patients. Yeah. In the patient community, we highly promote the idea of data sharing. We know that some patients won't benefit from new therapies, but others will do. And to the patient who don't benefit, this is still very valuable because they know that others will take advantage. Yeah. There is that sense of solidarity, and probably that's maybe what we need to make it more loud and clear to others.
Yeah, maybe we should call this European Health Data Solidarity Act. It would have been to that point. So I think we have to draw this to a close. Actually, we could have made it easy here and say, you know, all of the above, and everybody would have clicked that. But we want to tease out a little bit the nuances between these, right? So now we're going to wrap up, and I want to remind ourselves, and also building on what you said, Valentina, now we heard the Health Commissioner clearly address this in the way you did, that there's no contradiction between competitiveness and access and the social contract for public health in Europe. And we are ahead. Europe is ahead. Others are copying us, you know that. United Kingdom now has this health data research service, which essentially is a copy of the EHDS, I think. US, in the Make America Healthy Again plan, there is a whole section on real-world data. But we are better placed, I think, in Europe. Both the data is there, and I think we have more trust in governments. We have more trust in the private sector, surprisingly. We do trust polls in the United States versus Europe. So I think we're starting from a good position. So thank you all. This is not the last time we will talk about this in this valley. It'll be recurring. It's a long-term project, and I feel that we're all committed to make this work. And we count on all your support as well. So thank you very much, and enjoy the rest of the session. Don't forget to fill out the evaluation form on the way out. Anyhow, thank you so much, and thank you to the panel. Also online, Fulvia, many, thank you.